Hi, my name is Margaret, and I'll be critically analysing Lagrange and colleagues, enhanced cognitive behaviour therapy and family-based treatment for adolescents with an eating disorder, a non-randomised effectiveness trial. So researchers have informed us that eating disorders currently have an issue with relapsing in adolescents. And for this purpose, they inform us of the two very highly used treatment modalities in treating adolescents with eating disorders. So family-based therapy is the first line approach for treating anorexia and bulimia nervosa. And the second is enhanced cognitive behavioral therapy, known as CBTE. CBTE is very well established in adult populations, and it's been recently adapted for adolescents. So this was very important to address. Family-based therapy has been researched extensively in randomized clinical trials. Yes. So moving on to the critical analysis of the introduction. So throughout the introduction, there was no section dedicated to defining the constructs or interventions mentioned in this study. No theoretical frameworks were outlined either. Now, this introduction could have been further improved by providing these clarifications and frameworks, allowing the reader to have a specific understanding of the constructs and interventions used, especially if the researchers were referring to them quite often throughout the study. Now, secondly, the researchers noted that further investigation in the effectiveness of FBT and other treatment interventions, such as CBTE in adolescents, has been suggested but not examined. This is quite important as the researchers have addressed a gap in knowledge and are looking to examine this further. This was a major strength of the study. So bring onto the hypotheses. So the primary outcome of the study was to compare the relative effectiveness of FBT and CBTE among adolescents with the DSM-5 eating disorder. The secondary outcome was to examine which treatments might be more optimal for different patient groups. Now, there was no clear research question or aim specified in this study, but the researchers did imply through their primary outcomes and secondary outcomes of the direction of where their results might lead, but this wasn't very clear. So they may have improved on this by elaborating a bit more for the reader. Moving on to the methods section. The researchers were able to offer the participants two different treatments. They were either able to choose FBT or CBTE. Details of the demographic of participants, procedure and assessment, and intervention details were quite elaborate for this study. And moving on to the critique of the methodology. So researchers did not provide any information on the internal consistency or interratability of the scales that they used. These figures are important to note because internal consistency or interratability suggests that results can be reproduced using the same scales and conditions in future studies. Furthermore, they did not include any scores of construct criterion or content validity. These are really important because it helps the reader to understand, generally speaking, that this scale is measuring what it's supposed to be measuring. And given the non-randomized nature of the design, researchers weren't able to achieve internal validity either. But the purpose of the study was to address the effectiveness of the intervention. So internal validity was not really the focus of this study. Further to add, power analysis was not conducted. So the researchers were quite at risk at type 1 error, where they might have concluded that an intervention was effective when it really wasn't. Despite this, the treatment assignment was quite generalizable and consistent with real world settings, where patient and family preference is accounted for. So greater external validity for this study. Moving on to the results. So the researchers were able to outline their results through their primary and secondary outcomes chronologically in order. And they were able to outline specific periods of their assessments during baseline, end of treatment, and their 6 and 12-month follow-up periods. This is really important for the reader to understand at which point significant differences occurred. There was some mention of testing for confounding variables, such as treatment effect moderators. But in terms of a therapist or parental influence, this was not controlled for, and this would have helped in minimizing type 1 error as well. So in terms of the discussion, the researchers found that FBT was more efficient at baseline to CBTE, but at 6 and 12-month follow-ups, there was no differences. So it turns out CBTE is quite suitable for older adolescents with lower levels of weight and depression. And FBT might be more suitable for younger adolescents that might require more parental involvement. So the findings indicate that CBTE is quite on par with FBT. This study was really important in highlighting the differences of effects of adolescent groups. So younger and older adolescents require different interventions for different needs. Older adolescents might respond differently because they might require more autonomy and independence, hence might prefer CBTE, whereas FBT for younger adolescents involves more parental involvement. So this was quite desirable. So yeah, and CBT is actually quite preferred when adolescents don't have access to their parents or do not have parental support. And this study was really able to highlight this. Now, the researchers did not mention this. This is something that I believe. A major strength of this study was that it was able to compare FBT and CBTE. This has not been done before in a clinically relevant sample, and it had great external validity, and the clinician training was quite high throughout all levels of assessment. So that was a major strength. The limitation of the study was that the normative data was based on UK samples, and this sample was utilizing USA participants. So that was one of the major limitations. Type 1 error was not controlled in terms of the fact that this study was not high in efficacy, but more focused on effectiveness. Yeah. So implications for future practice. So this will actually allow future practitioners to understand the differences between adolescent age groups, and the fact that older adolescents might need different interventions for younger adolescents. And this allows for, the comparison of interventions allows for practitioners to understand and learn to promote different interventions for different adolescents. And lasting change is quite important among eating disorders, as it is quite difficult to treat. And now that there is more research on CBTE being a more cost-effective intervention for adolescents, this will definitely be able to be promoted in schools or by teachers, and really allowing for the application of psychology to be further reaching those that really do need it. Yeah. So this is the end of my presentation. Thank you for listening.